Anyway, good afternoon and welcome back to all of you with us this morning, and welcome afresh to those joining us for the first time now. Some of you might have seen some interesting videos running through the lunch break. Don't worry if you didn't, because they'll run again after a short gap at the end of the afternoon session. My name is Brendan Martin, no relation as far as I know to your host this morning, Helen. And I'm the founder and managing director of Public World, a business-to-business social enterprise working for great care, joy at work, and strong communities. We've also founded Buurtzorg Britain and Ireland in partnership with Buurtzorg in the Netherlands, and have supported not only our colleagues in Kent as part of this project, but also hundreds of other nurses and caregivers and their organisations and others, and other organisations all over these islands. This morning, we heard about the origins and purpose of this project from Alice at Health Europe Centre and from Buurtzorg founder Jos de Blok about why he founded Buurtzorg and how it has grown. As this project shows, Buurtzorg has become the inspiration for health and care professionals and many of their organisations all across the world, but it's also an international beacon across many other sectors, inspired by its commitment to putting humanity before bureaucracy and keeping things simple in self-managed teams. I was particularly excited to hear from Jos this morning about Buurtzorg's most recent initiative, an inspiring model of developing healthy neighbourhoods that can care for themselves, with professionals and institutions on tap, but not on top. For us in Public World, its ambition resonates well with the purpose of our own conference, Caring Places, Building Healthy Communities, supported by TICC and Buurtzorg, and held a year ago this very day in London and online. We look forward to learning as much from Buurtzorg's latest innovation as we have from everything Jos and his colleagues have achieved over the last 15 years. Public World's role in this project has been to provide learning and development support to our partners in Kent and to gather together evidence from all the project partners about the experience of bringing the Buurtzorg way into their organisations and systems, or as Sue Wilson of Medway Community Health put it this morning, retrofitting. We heard some rich detail this morning, and this afternoon we'll hear more from other representatives of the TICC partner organisations about the barriers and challenges they've encountered along the way and the solutions they have tried in overcoming them. Between us, we've identified nearly 300 particular challenges, which we've grouped together into 4 categories in our analysis. That material will inform the written product of the project, which we hope will be a guide to health and care systems all over Europe and indeed beyond in the years to come. My colleague Rachel Way will give an introduction to those themes and to the colleagues from France and England who will illustrate them in more detail this afternoon. Of course, although this project is coming to a close, its real benefit will be shown in what happens from now on. So we'll be hearing also later in the afternoon from French and English colleagues about how they're working to take the learning forward in their organisations and systems, as we hope many, many more will do with the guidance of the documentation coming out of the project. Public World has been asked to host all of that material on our website at the end of the project, which we're very glad to do. And we've also created a brand new online community of practice open to all, not only partners in the TICC project, but the many others we hope will be inspired by its results and its learning. That site, like this conference, is called Humanity at the Heart, and it's gone live this very day. And participants in today's conference will receive details of how to join it after the session. We're very confident that this project will indeed provide inspiration well beyond Europe. So it's fitting that the afternoon will close with David Stewart of the International Council of Nurses, exploring how the health and care challenges we face in Europe are just as urgent elsewhere in the globe, and how the Buurtzorg way and the learning from it, from this project, can contribute to tackling those challenges. But before all of that, we'll hear from our partners at HS University of Applied Sciences and the Catholic Institute Hospitals Group in France, who've been responsible for the evaluation of this project itself. So now let me introduce Sibren Slimen, who will lead that part of the afternoon session and introduce you to his colleagues. Sibren.
Thank you, Brendan. Thank you for the introduction. Hello, everyone. Welcome back to the afternoon session of the TICC final conference, where we will start with the evaluation part. Hope I'm loud and clear for everyone. But before I start, maybe some small house rules to say. So if you get questions during our presentation, please use a chat. We will be aware of the chat. We're with 5 researchers here today, so we can answer it straightly. Otherwise, we will answer it during the Q&A session afterwards this afternoon. Thank you for that. So during and before and besides the realization and implementation of over than 250 TICC teams in this project, we looked at the impact of the implementation on staff, on patients, and on informal caregivers in the TICC project. In this project, there were 2 research partners. First of all, the organization where I work with, HS University of Applied Sciences, and we focus mostly on preventive health research and social inclusion. The other research partner here is Lille Catholic Hospitals, which are more focused on biostatistics. Please be aware that the results we present during this conference are preliminary findings. We're still in the middle of the data collection period, and we will end the research data collection in the end of December 2022. So please be cautious by interpreting results that we present today. My name is Sibren Slimme. I'm here with my colleagues Ingrid Snijders and Marijke Mulder. And from Lille, here are the colleagues Stefan Verdun and Gabriella Sertat, who will present later on this day. We did both together the actively involved research part of TICC. What will be discussed today during our evaluation presentation? We will look at the basis of the methods we've used, the timeline we've used with those methods, and the outcomes that we've researched. Then we will present some preliminary findings based on the number of respondents, the readiness for organization of implementing the TICC model, the patient's quality of life and autonomy, the burden of the informal caregivers, and then we will focus on the care staff's job satisfaction, implementation experience, and autonomy. To round off, we will go to the expectations in future, what will we present in the final report in March 2023, and what is our scientific contributions, or the aim of our scientific contribution. To start with the basis of the methods that we've used, we used a kind of triangulation in this one. We started with literature research as a good basis, a good theoretical framework, where we highlighted the most important aspects to use as a topic list in the qualitative data collection, for example, during the focus group that we've done, but also to select the questionnaires in the quantitative data collection for patients, for care staff, and for caregivers. Next to that, in the quantitative data collection, we focused on the general data and the organizational system. Think of staff sick leave, working hours, and care costs. In the end, we also looked at the gap analysis in a CEO perspective and in a team coach perspective, which was subjectively measured in a quantitative questionnaire. I'll come to that later. Looking at the timeline, we started already in 2017, which is already more than 5 years ago. We draw up the first research protocol at that time, which has evolved over the years in time. In 2018, we finished the literature research, and we started with the first quantitative data collection before the team started running. In 2019, we started with the first focus group discussion and the gap analysis, which was a requirement of at least 6 months of experience in a TICC team. 2020 and 2021 were in the sign of continuation of those research methods, where we're still doing those. Also in 2021, we have, of course, the impact of the COVID experiences. And we interviewed some nurses and care staff, how they dealt with that. In 2022, at the moment, we are rounding off the data collection and reporting on the outcomes. And next year in March, we will present the final report and hopefully some scientific papers. The topics based on our target groups. Of course, we have the care staff, amongst others nurses, but also other related care staff. And we looked at empowerment, autonomy, general health, intention to leave, implementation experience in the TICC implementation, and the job satisfaction. For the patients, we looked at the autonomy, quality of life, both physically and mentally, and the quality of care. For the more academic people here, you think the NPS score is also part of the quality of care assessment. For the less target group, the informal caregivers, we looked at the burden that the informal caregiver perceived. The preliminary findings, the number of respondents. We present here the first visits, the first 2 visits of the number of respondents. Of course, at the moment we've got more than 2 visits, but to give an indication of the amount of respondents in the project, we just presented the first 2 visits as we're still collecting data. So what do we see? We have over than 400 care staff in the first visit, more than 200 patients, more than 70 informal caregivers. Visit 2 consists of more than 60 care staff members, more than 150 patients, and more than 40 informal caregivers. To present some first preliminary findings on results, I will start with the readiness per organization, as this is one of the methods that we've quite finished in the project already. On the right side, you see a figure which presents mind the gap. We want to go to a social innovation in this project. And the social innovation is the implementation or successful implementation of the TICC model in a new way of working with the benefits of it next to it. But at the moment, we're not there yet, or at least the moment that we started with this project in 2017. So which aspects were most important in the implementation of the TICC model to successfully implement it? We looked at the literature and had a lot of interesting conversations with expertise partners in this project and created 5 concepts that should at least be available within the organization to successfully implement TICC. Based on this concept, we created a score from 0 to 10 on what were your implementation grades, the gap analysis. Here you see the 5 concepts that we've used on the right side. The first one is policy and organization. The second one, educational aspects and nurse-based knowledge, financial modeling, methods providing for care, and law and legislation. On the left side, you see also some example questions for it. For example, for the policy and organization part, we asked the CEO and the team coach, did you work in small self-managing teams? Was the care that you provide a holistic approach? Did you provide integrated care? So in this way, we assessed those aspects in a more subjectively way. So the organizations assessed their own organization based on those topics. We did it 3 times, started in 2019, the second one in 2020, and the third one in 2021. Actually, in 2019, we started just with a CEO perspective, as we thought it would be sufficient for a good impression in where the status was. However, in contact with the partners, we decided also to include the perspective of the team coach, as it's more workflow related. So my question to you at the moment is to please use the chat. And who do you think that is assessing their own organization more positively in this gap analysis? Is that the team coach? Please press number 2, or is that the CEO? Please press number 1. I'm very curious what your thoughts are on this. Number 2. See 1 response in the chat, another one, number 1. Thank you. Wait for 15 seconds and then I go to the next one. Number 1 as well. Number 2. Number 2. Okay, it differs quite, that's nice. Anyone else that would like to respond, or others I will continue? Number 2, number 1, number 1. It's actually quite in balance at the moment. That's nice. Thank you for that. I will present to you what the results did say. Actually, the team coach assessed more positively on average. If we look at this figure, you see the readiness from 0, which means no implementation of this aspect at all, to 10 out of 10 is complete, perfect implementation of the TICC model aspects. On the first point, the CEO assessed it on average with a 6.3, and it evolved over time to a 7.3, which is quite positive. Also for the team coach, it evolved positively from 7.7 to 8.2. So being in TICC for a couple of years has caused a positive evolution over time in the perception of implementation of TICC aspect models. So this is quite positive over time. We cannot draw hard conclusions on this because it's not a significant result, but it is a nice trend to watch. If we look at it more in specific to the different parts that we've measured within this gap analysis, we see, for example, in policy and organization, that the assessment of the CEO and the team coach is quite similar. So they're both quite, on average, they're quite similar. However, the other one, all the other four ones are quite different because the team coach is assessing it more positively. However, all the aspects are evolving more positively over time. So there's an increasement in assessment, which is a good trend to see. And the interpretation of these results is very difficult because we do not know how it's caused and what the reason was for the difference in time. In the final report, we will also try to compare those results with focus group results with the quantitative questionnaires to see if we can more interpret those results. This is the gap analysis for now, and I will now give the word to Stefan Verdun, who will talk about the quality of the patient's life.
Thank you, Sibren. So indeed, I will talk a little bit more about the quantitative part of the analysis. So we had three main targets: the patients, the informal caregivers, and the staff members. First, for the patients, we measured quality of life and autonomy. Quality of life was measured by two main scores, two dimensions: the mental and the physical dimension of the health-related quality of life. We found a statistically significant effect on the physical dimension of the quality of life. For the autonomy, we use the IPA, the Impact on Participation and Autonomy questionnaire, which led to 4 scores measuring 4 different dimensions. However, it is to note that this questionnaire was not delivered by Vivat and Soignons Humains. So if we look at the results for the quality of life, on the figures, you can see the mean evolution since the first visit to all along the follow-up. We see a similar pattern for both mental and physical dimensions. In blue, you have the patients in charge by control teams, and you see that the scores are decreasing, which means that the quality of life as measured is decreasing. At the same time, in the TICC teams, the scores seems to be stable, maybe a little bit of an increase. So, as I said, we just found a statistical significant result for the physical dimension. However, the trend seems to be similar for the mental dimension. So, it will be investigated further in the final analysis to see if something confirmed on this dimension. For the autonomy, so 4 dimensions were assessed: the autonomy of the patients indoor, outdoor, its family role, and its social life and relationships. We found no impact of the TICC teams, and looking at the figures, it doesn't seem that a strong trends appear for any of the dimensions. The next target was the informal caregiver. The informal caregivers. We assess the burden of the informal caregivers using the Zarit burden interview. This questionnaire was not, those data were not gathered by Vivat and Soignons Humains neither. We do not find a statistical significant results and no difference between the two groups. However, looking at the mean evolution, it is possible that there is an increased burden in the TICC teams. However, so far it's still just an hypothesis, and it will need to be investigated further during the final analysis. For the care staff, we measure the exposition to psychosocial risks, the staff empowerment, and also we simply ask them, are you planning to leave? Of course, we did it anonymously in order to have the unbiased answer. So the rates of yes answered are quite similar in the two groups. However, as you can see, the number of respondents in the control team in the control teams is quite low. So those results need to be considered with some caution. And for the other dimensions, we do not find any statistically significant difference between the two groups. However, there may be some trends that should be investigated further in the final analysis. So, Sibren, can you go to next slide? For the psychosocial risk, it is possible that we have a positive impact on in TICC teams on work-family conflict, on social support from supervisor, and of quality of leadership. And for the empowerment, it is possible that the scores are better in the TICC teams. So if we want to summarize the results, we find positive impact of TICC teams on the patient's physical dimension of health-related quality of life. We have some trends and hypotheses that need to be confirmed or not in the final analysis. But however, we have some limitations and difficulties we have encountered that need to be highlighted. The data gathering was not easy for every partners because in fact it is hard to detach to give time to a team member to fill the questionnaire with the patients, to have the patient to be compliant with this. And also for some questionnaire, and particularly for the Zarid burden interview, some partners had very negative feedback from the people because the question can be seen as quite intrusive. So they prefer to draw back from this part of the evaluation in order not to impact their relationships with the family of the patient. And also, we did not manage to find control group for every partners. For example, in France, we did not found any control group. One of the reasons of this is because the potential control group were feeling that the team partner were more like competitors, so they did not want to be involved in the evaluation. So this is the main preliminary findings on this part of the analysis, but we will need to go more further in the final analysis. So Ingrid, your turn.
Okay, merci beaucoup, Stefan. So for the data gathering, part of that were the focus group discussions. What we did was, it was measured during 3 time points. First, the end of 2019, the beginning of 2021, and beginning of 2022. It was conducted by the care organizations and later on transcribed, coded and analyzed by HZ, University of Applied Sciences. So there were like 8 main topics, for instance, the implementation of the care model, but also working in a TICC team, and it was divided into 27 subtopics. This information was used for analysis by HZ as evaluation partner. To illustrate, we just use some quotes that were mentioned, as you can see. So let's go over to some of the findings. The responses from the focus group discussion among staff's experience of the implementation of the care model, overall it was positive. The answers indicated that there was a higher work satisfaction. The clinical tasks were divided based on skills, competencies, instead of, traditionally the ranking. And self-management was seen as important. However, for some nurses it was difficult because they had responsibilities in other teams that were more like standard teams beside their TICC team. The focus group discussions were also used to discuss the quality of patient care. The preliminary findings of the TICC team enabled a more holistic care approach that can be experienced in different ways. For some good, for some something to get acquainted to. Most patients enjoyed the autonomy they gained. Others found it in accordance with their care expectations, but some patients expected nurses to take care of everything surrounding their care. Some patients refused self-care or experienced holistic care very different from the conventional expectations. So it seems that holistic care is not fitting, is not for everyone a fitting care option, or at least it takes more time for people just to understand and adjust. Okay, so I think overall, thank you, Sibren. The focus group discussions among the countries, they indicate that trust in the host organization is very important, and it's also related to job satisfaction. Mainly what the care staff say is that stay close to the original TICC model and don't change the work approach too much. Working according to the model, it means working in a non-traditional way where hierarchy rules. Also, the way of care is different from traditional ways, and this is something nurses might hear and get back from patients at first. So as mentioned earlier, these are for now preliminary findings and that we need to combine in our further analysis. Okay, so what can you expect? In March 2023, the final report will be delivered. And till that time, as an evaluation partner, we will analyze the data, of course, whereupon we will base our final conclusions. But in addition to the project deliverables based on the data that we collected, we are working on a conceptual model. So let's have a look. In this picture, what do you see? Please add your comments in the chat. A grandma, okay. Okay, a woman looking away, yeah. I see a lot of you see the young woman. Okay, good. Let's stick to the young lady then. Oh, good. Somebody sees both. I'll get back on that later on. Okay. So part of the data that was gathered for the TICC project was among care staff and their intention to leave, which you can see over here. We expect that employee empowerment will have a negative influence on intention to leave, or in other words, when you feel that you are in control, you are less likely to leave your job, right? And psychological stress will have a positive influence on intention to leave, or in other words, the more staff experience stress during the work, the more likely they intend to leave their job. Yet what we can see is things in a different way. So then again, and not for the person who saw both, can you see the other picture over here? So for the people who saw the young woman, do you also see the old lady over here? You get, yeah. So you can see the nose and the chin over here, or the young lady looking back. And this is exactly, I think, when we look at the same things, but differently, intention to leave might also be considered as intention not to stay. So within a conceptual model, we position our outcome variable as intention to stay. And then employee employment is hypothesized to have a positive influence on intention to stay, meaning that the more feeling of empowerment, the more feeling to stay is within the job staff has. And instead, the higher psychological stress care staff experience, the less likely they are to stay within their job. So let's have a look at the overall model. Either we investigate intention to leave. In our model, we have two independent variables, empowerment and stress. To measure these variables, we used valid measurement instruments. For employee employment, it was the instrument by Spritzer, and the Copenhagen psychosocial questionnaire was used for psychological stress, which is a well-known measurement instrument for assessing like psychological factors at work, stress, well-being, etc. So part of the data that is collected during the TICC project, we want to contribute to the existing literature and show some practical implications and do some recommendations. Our aim is that we provide healthcare organizations what factors might influence care staff's intention to leave, either to stay, and indirectly for job satisfaction. To do so, we must further examine the responses to the questionnaires. What we want to know is how the measurement instruments worked among the TICC respondents, because within the literature sometimes we see that although this is a valid measurement, the questions we ask, sometimes they do not completely measure what we really wanted to do in our context. And secondly, we aim to show some results that indicate empowerment and stress as predictors for intention to leave, stay. And we use, for the ones who know it, I'm not sure, a partial least square structure equation modeling analysis. So actually in this way, we hope that working as a TICC team will get more notice internationally. And for now, I really want to thank you for your attention.
If you have some questions and you have interest in the final report, you can of course email us for more details about this presentation or about the results. Otherwise, Q&A session, we will try to solve all the questions that were raised in the chat, or you can ask still questions in the Q&A session. So thank you for that. And Brendan, I give the word back to you now.
Thank you very much indeed, Sibren. Thank you to all of you and all of your colleagues for those fascinating and insightful findings, albeit based, as you said, on the limited data available at a much earlier stage of the project. And we look forward, of course, to the further analysis in the final report. It seems that the teams, from what you say, have been formed to provide, the teams that have been formed to provide care in the Buurtzorg way in this project have had an overwhelmingly positive impact, even if some aspects are clearer than others. And it's important to remember that the purpose of this project is not primarily to discover whether the Buurtzorg approach can work outside the Netherlands, because at the end of the day, whatever the institutional or cultural differences between countries, the fundamentals of putting humanity above bureaucracy are surely universal. The point of this project has been to build our understanding of how this approach can be applied in different environments than the one in which Buurtzorg has been so successful, and to look at what organizational and systemic challenges are involved and need to be overcome. That's the focus of the next session, which, as I said in introducing the afternoon, draws on the nearly 300 barriers and challenges identified by the French and English partners as they've introduced self-managed teams into organizations and systems in which there are radical innovation. So we'd expect some benefits to take time to show as organizations grow their understanding of how they need to change to support a shift from time and task delivery models to more relationship-based approaches, and from command and control organizational cultures to workplace relationships based on serving and supporting the frontline professionals in self-managed teams and building trust. So to look at those experiences, I'm going to hand over to my colleague, Rachel Way, who in turn will bring into the conversation a number of our partners in France and England. Over to you, Rachel.
Thank you, Brendan. I'm just going to share my screen with you, and I hope that that's visible to everybody. So good morning, everyone, and afternoon. I am Rachel Way from Public World, and I've enjoyed working with our many colleagues over the last 4 years, and I thank them for trusting in me to talk about the barriers and challenges that they've all experienced over the last 4 years. As we've been hearing this morning, the work completed has brought about many benefits and experiences for all those involved. And I particularly enjoyed listening to the experiences of the patients and the staff who are central to all of this. In practical terms, this project has been as much about identifying the barriers and the challenges that organisations face when looking to alternative models. In fact, the application form from this project lays out a clear plan to develop a blueprint for any organisation that would like to make transformational changes in line with a particular model or approach, whether that be the Buurtzorg model or indeed something else. Its role is to consider how we might share best practice across borders and how we might overcome those challenges, not least those of the political and institutional factors in each area. And as you've heard, we've looked throughout this project to review the experiences of all partners, whether they be in the UK, France, or Belgium. Whilst we are producing a report that lays out the many considerations that should be made, would we call it a blueprint? And actually, in our opinion, that is not the case. A blueprint suggests a direct map, a lifting of one approach into another. And if this project has taught us anything, it is that we all have the need to do things flexibly for our own experiences. Therefore, whilst we call it a blueprint, we hope you'll find that it is actually a very useful guidance on all the things you should consider when looking to implement, I know it's a word that we're not all comfortable with, someone else's model. As Brendan said, there are a good number of barriers and challenges that had been recorded across the different organisations, different countries and different teams. More than 250 items that we've responded to where it was possible with solutions or at least attempts at. Some of these have been so challenging and so out of the remit of our work, you'll see that they're often at a political or sector level. For example, there was no way for us to change the way the NHS runs, or indeed how insurance companies cover risk. They were not in our remit. But we have recorded progress we have made when liaising with policymakers and government representatives, and hope that this project adds to the significant voice of the professionals looking to make significant change to the environment in which we all work. Others have been much easier to overcome with training or support, or indeed conversation with the staff experiencing the challenge. But far from wanting to go through all of those experiences one by one, I suspect you'll all be switching cameras off and having a doze after number 10, we would like to share with you some of the key findings. How, in analysis, we've found the barriers and challenges can be categorised, some of the big wins in terms of solutions, and lastly, the opportunity to ask partners about how they overcame some of the items that I'm sure are already questions in your own heads. So our key analysis found that whilst we could categorise the barriers and challenges in a number of ways, we could look at them in terms of whether they were a French challenge or a UK challenge. We could think of them in terms of the departments that they affected or the work stream. Think recruitment, policy and regulation. Perhaps it would be competition or workforce. You will find that the records of the project do provide you with the search function of these headings. However, the blueprint will look at them slightly differently. We look at them in terms of the organisation and institutional environment, areas that relate to values, culture and their goals. Challenges that result because of the national community nursing environment, those that relate to the host nation's policy, regulation, format, insurance or education. There are challenges at the level of the model we are working with. Think barriers and challenges that arise from learning something new or that doesn't really fit within the culture of the organisation and the way they have done things before. Lastly, those challenges that arise because you're looking to change or transform something everybody knows and feels safe with, even if it's not working the way it is. You will note, I'm sure, that there are plenty of crossover as I go through these, and that is because many of them do interrelate or touch on more than one particular area. So first of all, we're going to start with the organisational challenges, which make up a considerable number of those recorded. I'm going to go into these in a bit more detail than some of the others, due to the nature of the audience that we have with us today. And in themselves, they can be broken down into 4 areas. Inconsistent organisational goals, a lack of integration at all levels, hierarchy and competition, and systems-led working. And we're going to start with the inconsistent goals through the organisation. Staff found themselves trying to meet the objectives of the model while still being monitored and evaluated in another. There is a long-term goal to look after someone holistically and decrease the amount of care needed over a period of time. Currently, both in France and in the UK, organisations are paid per act, and in the UK's case, in blocks of time. It was found that commissioners do not understand or recognise the value of the model yet, or know how to commission differently. CQC monitoring requirements is another example. For France, there were challenges with insurance companies who put too much emphasis on financial goals and not enough on the quality of care, which impacted the happiness and motivation of team members. For French partners, this imbalance between the 3 pillars of the Buurtzorg outcomes meant that staff were feeling pressures about the financials when their attention needed to be on the great outcomes for their patients. But it is, whilst I'm talking about areas that perhaps look like they're more institutional and more top level. It's actually for the organisations to support staff to do their best work in the new model and protect them from the inconsistencies of the goals whilst the transition is taking place, to reduce the level of reporting needed, to protect them from other areas of the organisation who've not yet thought about their new roles and responsibilities. It's perhaps one of the more challenging issues in taking a step-by-step approach, not to say that this is the wrong one. Lack of integration at all levels. Health and care being part of the same service is key to the success of the Buurtzorg model. And as I said earlier, it's been an ambition to create greater alignment between the two in many countries around the world for a long time. Getting to know the social, personal and health needs of a person and addressing them as one creates huge efficiencies for our systems. However, it is exactly this lack of integrated thinking, funding and working that was a consistent barrier for those working on the project. For Kent County Council, for example, the lack of connection between the two and the difference in regulation for carers and health workers that prevented them from progressing with their intended teams. And I'm going to pass to Alison now to share just a little bit more. Alison, over to you.
Thanks, Rachel. Afternoon, everyone. At Kent County Council and between some of the the UK partners, we had an ambition of creating a blended team approach where we would have a mixture of nurses and care workers within a team. And our approach was for the care workers to learn some basic nursing skills from the nurses within the team to really kind of build on that blended approach throughout. So if the care workers had those basic skills, it would free up some of the nurses to do some more of the complex nursing work that was required with the patients that they were seeing. Unfortunately, we weren't able to fully commit to that approach. It wasn't for the organisations not wanting to. We did have care workers within one of the teams within the UK, and they got on really well, and it seemed to be working well with care workers going in and doing their part and their tasks, and then the nurses doing theirs. But again, that kind of was a separate approach. And working towards the blended approach, we come up against the barrier of insurance. Unfortunately, as an organisation, we weren't enabled to insure our care workers to complete the nursing tasks. And from a health perspective, organisation, they weren't able to ensure our care staff to complete nursing tasks. So we kind of really hit a barrier where no one was willing to ensure the care workers to develop their skills in health care related tasks and to really promote this new team, this new way of working. So unfortunately, we had to continue with the care worker role and the nursing role. And they did get on very, very well as a team. However, there was that separation due to the different tasks that each other were doing.
Thanks, Alison. I know it's been hugely frustrating for you that you weren't able to do more, but it's these siloed regulatory frameworks, health and care being funded separately and differently, policies and process and rules differing, and in the case for French partners, the law that prevent nursing teams employing care workers. All of these challenges, they're all examples of the difficulties that are faced when there's a lack of integration. We move on then to hierarchy and competition. The strength of the model lies in trusting staff to use their skills, their expertise, their training and their personal experiences to meet patient needs. And one of the first times I heard Jos speak, and one of the first times I had an opportunity to talk to him, and he explained about trusting in people, that we've all got our own life experiences. We all look after people at home, whether they be our children or our parents. We all manage our own finances. We all manage to look after our day-to-day routines. With this project, all partners were working in a hierarchical way prior to this project, and all have experienced the challenges of handing over the reins to those on the front line, from mileage claims to not providing clarity about who had autonomy over what, management sign-off on purchasing, a lack of framework or team agreements. This is all going to take time, but what is vital is a commitment to overcome these promptly and unreservedly. Without that, the teams will not feel the changes, and they're going to struggle to demonstrate how successful the model can be. By resolving them quickly and decisively, the organisation can immediately demonstrate a rebalance of trust. For KCHFT, this was done very well with the review of policies, and by passing to staff the opportunity to almost rip up unneeded rules and policies, they started to see a shift early on. There was huge benefits not only in reducing unnecessary reading on induction to start with, but it showed the staff they were being heard, that they do have responsibility and accountability for themselves, and that management would hear them and support or act upon their views. This commitment from other levels in the organisation is vital. Oops, sorry. Sorry, I lost my place there. This commitment from other levels in the organisation is vital. But we heard that senior managers with overarching responsibility felt anxiety about letting go. We heard that executives and corporate managers were nervous about the redevelopment of functions being passed to more junior staff. And you can imagine, I'm sure, that it also leads to competition. For some staff, they felt at risk, the perceived loss of status of a hierarchical position. They had a lack of willingness to do tasks that were perceived to be below their rank, and they felt a perceived loss of power. Communication through the transformation is, as it always is, incredibly important to people understanding what this means for them, whether they would be made redundant, given a different role. For French partners, it was even more difficult to keep people updated because of their inability to publicise. For them, the unions believe that the model will kill the self-employed nurse system. But many of these barriers and challenges can be overcome with consideration and communication about the intentions, and therefore a joined-up integration of the work streams. Lastly, at this level, we look at the systems-led rather than the purpose-led. For every partner organisation, the starting point for implementation of the model was the teams. Get started with them, work everything else out from there. However, when discussing with some of the partners what they would do differently if they were starting again, we were told that actually they would do much more with the senior leadership and the back office support service to the teams. We found a good number of the barriers and challenges actually related to systems. Do the systems fit with the new values and working practice? Do they empower staff to know more relevant information? Often our systems are built to allow management to see what is happening and what to question. Actually, for Buurtzorg, the systems being useful for the staff is a much more important approach. We don't want systems that tick boxes or report information. We want systems that allow the frontline staff to make the best use of the IT of today for the work they do. Yeah, of course, it can still respond to the regulatory needs and questioning, but first and foremost, it needs to work for staff, individually and as a team. This shift from a head office, we tell you what to do and you do it, to a back office, let us support you to do your work. That's a big one. And it needs planning and timing. And the journey of transformation affects every member of staff, no matter their position, role or rank. And to avoid the being done onto by the head office to the front line, it is an all-in approach and everyone learning together as they go in an iterative way. Then we move on to the national community nursing environment, which is different from the Netherlands to Belgium to UK to France. And as a result, it is no surprise the landscape of the services in each country contributed to the challenges, but also to some of the more difficult challenges to overcome. In fact, it is fair to say that it was not the expectation that we would, as a partnership, be able to change the landscape in our countries, but that we might have a shared voice of experience for our leaders to hear. This was very much the case for the French partners, and I'd like to bring Guillaume in here. Guillaume, what has this project meant for you in terms of the challenges that you faced and how the national environment needed to change, and how receptive have they been to that?
Thank you, Rachel. So thanks to the TICC project, we could start a few teams back in 2017, and quite soon we could see that the finance model of nursing care in France was not aligned with the goal of delivering holistic care. So the common system is about 90 different products, ranging from 15 euro per hour to 200 euro per hour, depending on the product you're delivering. And some patients are valued 3,000 euro per month, and some other patients valued 300 euro per month for the same amount of minutes of care. Then it's quite perverse and inefficient system, of course. Perverse for the patient and the professional, and inefficient globally for the system. So the TICC project enabled to show this and to put it into the light. Then we had the opportunity with the Ministry of Health to propose on top of the TICC experiment a different way of paying for the service, and it's been accepted. So now since 3 years now, the TICC teams could operate with a different scheme, a per hour price of 54 euro per hour with the patient. And of course, it made a lot of difference. And we could eventually stick to the TICC ambition to transpose the Buurtzorg way, including the HOMAHA system vision to support the holistic vision, and including this, almost the maximum we could do. We couldn't overcome all the challenges because, as you said, for example, we still don't have the possibility to join within the same team assistant nurse and advanced nurse. We have to be only nurse. So there's still a way to go to have a real integration of care. But still we had a great opportunity, I must say, to mix the Interreg TICC and the national experimentation on health. That's does that answer, Rachel, your question?
It does indeed. Thank you, Guillaume. In addition to some of the items Guillaume mentioned there, it's also the case that there are barriers and challenges at much wider scale, international in many cases. We can't, of course, ignore the global pandemic that dramatically impacted the work. And as a result of that, as well as the perceived lack of respect and appreciation for this actually skilled work that our nurses and care workers do, means that the recruitment of staff into these roles is extremely challenging. The reduction of investment for education of future workers. We were really pleased to see that for all partners, the promise of a renewed way of working, it actually drew in more to apply for the roles. And I know that's particularly true in Arnold's case, and certainly in Medway and KCHFT as well. The ability to re-advertise roles with the description of how they would work differently really did draw in new recruits. But the fact remains that they're still under-resourced, underfunded, and in addition, a significant increase in need and therefore caseloads. Whilst there are, of course, crossovers in the challenges experienced, there were a number that related to the model itself and specifically around the collective working. So a number of points. Firstly, communication. Communication's always a challenge, doesn't matter the project or the organisation. Even Royal Mail is a communications organisation that has challenge with communication. But in relation to the model, it was found that there's much more efficient ways to communicate and that actually team members really not used to being in direct contact with their colleagues. Another is conflict and challenge. That was very new to people. In our hierarchical approaches, we often find staff run to management to help resolve difficult issues. And so they really weren't used to having difficult conversations. Staff found it hard to be open and honest with each other. Some personalities were able to do so more easily than others, but it really is a case for trust, psychological safety, training, and the role of the coach. There were challenges with the equal sharing of jobs. Some of the roles that Buurtzorg share out and rotate within the team, certainly in the early days, felt like a heavier burden than others. And you can, I am sure, imagine that there are those that take on those roles and responsibilities much easier than others. And as some take on those responsibilities, or indeed are expected to, as perhaps they've been more senior in the past, that leads to competition and sort of assumed hierarchy. Lastly, it was found by some partners that it was still incredibly important that staff feel valued for their experience and their knowledge and the time that they've been working. So it was very much a case that partners needed to find ways to demonstrate their respect and appreciation. Sometimes that was done through the responsibility for setting up new teams, for example. But without that recognition and paying respect to experience, for some partners there was a risk that their staff would leave. Lastly, change. Some love it, some not so much. Some will adapt quickly, others need time. And there are, of course, lots of steps that we can take to support change. And the blueprint that we discuss here is about just that. Some of the barriers and challenges we list are those that could be or were resolved with planning, communication and thought. We've already covered the aspect of integration and some of the challenges that arise in taking an approach where part of the organisation carries on as normal, whilst the pilot teams get started. We have to consider, especially at the moment, the capacity of staff to manage change alongside this business as usual, especially when they're under so much stress already. Considering the training needs, not just for the learning about the new way of working, but there are all these additional things that we're going to ask them to be doing. So using IT that's different, how to interview staff when they take on their own recruitment. There are additional tools to use or learn, which needs time to get used to it, or they might not be in place yet. With Buurtzorg, teams have a dashboard which shows them key data about how they as a team are performing, which is key to the financial sustainability for the organisation as a whole. But until organisations decide to make a permanent move, their models are often not put in place. In addition, the back office shift may not have been made, and there is a time period where things can be challenging if they're not planned and thought through. Partners recommend that enough time and support is built into the formation of the new teams to enable them to learn their new way of working and get used to the approach. So, have I put you all off yet? I do hope not. It could really feel like this is a big and unwieldy task to undertake, but throughout the project, for each of these barriers and challenges, there have been solutions. Many, in fact. Some of them have been really short-term challenges, only an issue through the piloting phase. Some we hope we've prevented entirely by sharing our experiences with you through the documentation. But partners have been really creative, and as well as just taking a status quo approach, they have managed to find workarounds, which are great for small and short-term pieces of work. But as an organisation, you need to remember that that will need to be changed ready for the larger scale projects or moving to a full organisation transformation. They do become crucial. For some, there have been alternative systems or additional approaches to particular changes and challenges. Some of the challenges will not leave you whilst you stay split with the traditional approach and the new approach. At some point, there is a whole full integration that has to happen. In any of these scenarios, clarity is king in terms of frameworks and agreements for the team. They define the mutual responsibilities and the distribution of authority, and at the heart, the shared purpose is the fundamental element of it all. Back to you, Brendan.
Thank you so much, Rachel, for that very clear and concise explanation of the many barriers and challenges that partners have identified and some of the solutions. And I hope, and I'm very confident, in fact, that what you've told us today so clearly will have whetted everybody's appetite for the final report, where we will not only give a brief analysis based on the structure that you've just introduced there of what we have found and what has been reported by our partners in France and in Kent, but also the documentation at the end will also provide, for those who've got the stamina for it, a lot of detail about each and every one of the barriers and challenges that have been reported and some of the detail of the solutions that have been found. So thanks again, Rachel and Alison and Guillaume. Now, with, I hope, the benefit of the report that will come out from this project, of course, as I mentioned earlier, the legacy, what happens next, how we build on the learning, how we learn from the barriers and challenges, what's needed systemically and organizationally to enable nurses and other care professionals to work in this way. We're going to turn to Pierre Vasseur and his colleagues to discuss how they're approaching the legacy from this project in the changes they're already making and are building upon in France. Again, I'll leave it to Pierre to introduce his collaborator. Over to you, Pierre.
Merci Brendan et merci Rachel.
Thank you, Brendan. Thank you, Rachel. I'll be speaking in French this afternoon. My name is Pierre Vasseur. I'm the European Project Coordinator for La Vie Active, a partner and operator for this project. So if you're not overly familiar with these European these projects, we're an operator/partner, and we joined this project in 2017, just like Vivat did, Soigne did, and we tried to be inspired by the Buurtzorg model and adapt this to the French context in order to improve home care in our country. So, quite briefly, I'll explain who La Vie Active is. I don't have any slides, I'll just explain this myself. And then we've got a 4-minute video which presents the team, the caregiving team that was involved in this experiment over the last few years as part of this European cross-border partnership. So La Vie Active was created in the 1960s. It's been recognized as an association in the public interest. We now represent 90 establishments in the north of France and in the Paris region. And all of these services, and I can't give you the exhaustive list, but we cover different types of vulnerable patients and beneficiaries. And we work with elderly people, notably. That's why we're here this afternoon. So this afternoon, we're focusing on home care services. My colleague, Barbara, presented a little bit about what we do. This morning, she talked to you about her role as a coach as part of the Buurtzorg experiment. So we and I imagine our partners, we joined the TICC partnership. Well, from my point of view, I believe that we were inspiring ourselves and other practices to be able to look at really what we do and to question how we do things. As Barbara was saying this morning, before we launched this TICC project, before we were invited to join this consortium, we knew we had certain issues as regards the attractiveness of the role of caregivers. And so we decided, why not? Why not try cross-border experiment, look at other practices, experiment with this new structure as identified by Buurtzorg. So we launched this transformation. And before showing you our short video clip, we've had very positive feedback. I just want to say that first of all. And so for us as an association, non-for-profit organization, we want to make sure we continue with this in the long term. So I now want to show you this short video clip, 4-minute video clip, which shows you the range of transformations that we have seen during this 4.5, almost 5-year experience of cooperation, and then we'll move on to talk a little bit more about the legacy. Well, I think we're starting the clip, so this clip, by the way, is subtitled in English, so don't worry. Please go ahead.
Depuis 2017, l'équipe du service de soins infirmiers à domicile, le SSIAD, est engagée dans un projet de coopération transfrontalière européenne appelé TICC pour se transformer et améliorer la qualité de ses services de soins à domicile. Cette transformation du SSIAD s'opère grâce à sa coopération avec 13 partenaires français, belges, britanniques et néerlandais, notamment en s'inspirant d'un modèle de service de soins à domicile néerlandais appelé Buurtzorg, ou soins de proximité. Il s'agit d'un modèle managérial dit auto-organisé qui fait ses preuves depuis plus de 13 ans aux Pays-Bas, car il a permis au personnel soignant d'être plus autonome et plus épanoui dans leur travail, ce qui a un impact positif sur la qualité de prise en charge soins des personnes âgées et de leur satisfaction.
Alors nous sommes une équipe autonome, ça demande beaucoup d'organisation, c'est pour cela que tous les lundis on a pris l'habitude de se faire une petite réunion pour un point patient et aussi traiter les affaires qui sont en cours. Par contre, on prend les décisions à l'unanimité et tout ça sous le regard bienveillant de notre coordinatrice, directrice infirmière qui prend aussi la casquette d'un coach.
Pour moi, être coach dans le projet TICC, c'est avoir un rôle facilitateur pour l'équipe, pour les accompagner dans la prise de décision, les aider dans la résolution des problèmes qu'elles rencontrent. C'est également de créer les conditions les plus favorables pour elles pour travailler au niveau des échanges et de la qu'elles doivent réaliser, et tout ça en respectant le cadre de fonctionnement de l'agence régionale.
Via un logiciel créé sur mesure qui nous permet le suivi individuel des patients et nous est accessible sur tablette et sur nos smartphones. Ça comprend la collecte des demandes, l'analyse de la faisabilité de la mission, la réalisation de la visite initiale et également l'inclusion dans les plans de soins.
Maintenant, c'est l'équipe qui prend en charge le planning. En fait, il y a 2 à 3 personnes de l'équipe qui élaborent le planning sur papier, ce qui permet de consulter l'ensemble de l'équipe pour les desiderata. Grâce au projet, on a également des téléphones portables qui nous permettent de consulter directement les tournées le matin. On peut également consulter les tournées pendant notre poste du matin selon les collègues où ils en sont dans leur tournée, s'ils ont un souci ou pas. Ça nous permet également de, si on a un problème technique sur la voiture, car on a des voitures professionnelles, d'appeler le garage et de prendre rendez-vous au cas où une panne non urgente ou une panne directement, on appelle l'assistance.
Nous intervenons dans le secteur Hénin-Carvin, 14 agglomérations, 112 km². Notre logiciel nous permet de gérer les tournées des patients à distance et en temps réel.
Donc, auparavant, la directrice infirmière du SIAD gérait la coordination avec les professionnels de santé. Maintenant, c'est notre rôle d'interagir avec eux. Donc, nous pouvons éventuellement trouver leurs coordonnées dans les dossiers des patients. Par rapport au budget du SIAD, nous pouvons dire si ça correspond ou pas. Si ça ne correspond pas, nous pouvons faire appel à d'autres prestataires pour le patient.
Sous la supervision de notre coach, nous sommes désormais impliqués dans le recrutement des nouveaux membres de notre équipe. Nous recevons les CV, nous sélectionnons les candidats et menons les entretiens d'embauche. Adhérer à nos nouvelles valeurs récemment instaurées est pour nous l'essentiel pour rejoindre notre équipe. Et par cette nouvelle approche de recrutement par les pairs, nous constatons que l'équipe du SIAD est beaucoup plus soudée et beaucoup plus stable.
Voilà, merci.
Pierre, may I just interrupt you 1 second?
Yep.
Excuse my intrusion. I just wanted to encourage everyone to start to put their questions for all of the panelists into the chat box so that we don't have a delay before the question and answer session and discussion after your session. And this is something I should have said before introducing you. So apologize for that, Pierre. And now back to you.
Merci. Aucun problème. Donc vous l'aurez compris dans ce film.
No worries. As you understood in this clip, it's all about empowerment. I really wanted to insist on this. The majority of the staff that you saw in the video here were caregivers, and for those of you who manage teams with care assistants, it was not always easy because these people had to step out of their area of comfort, their comfort zone, because some of the staff in these teams had been working for many years and they were just really used to see a coordinating nurse who was there giving them their schedule, and it was really a top-down approach that they were really used to, as Barbara was saying this morning. And now we realize that with this empowerment, it's been... Oh, sorry, I've lost the word I was looking for, but I think empowerment is really the key word. And in the clip, I think what's important is the values. It's helped to bring the team together. Our team has made its own rules now, based on a list of values. They've brought in regular weekly meetings that they manage to coordinate themselves. And during these meetings, communication is really important. Maybe it seems obvious, but communication is actually not always that easy within teams in reality. So they've really focused on that. Decisions are taken unanimously, based on a consensus, and they looked to the recommendations of the Buurtzorg model, focusing on the method, focus on solutions, trying to find their solutions to the problems they faced. So that's how they're set up. But what is also important, as you will have seen in this clip, is that we've had to really digitalize. As Barbara was saying this morning, before the TICC project, the SIAD just used paper. We had a secretary who then wrote everything down, copied everything down, So the teams out in the field were not at all involved in this type of thing. So this digitalization with this piece of software that was really inspired on the Omaha piece of software, which is used by Buurtzorg, it's really helped us. It's really how we were able to launch this TICC project and really see its value. So the care staff are now autonomous in terms of their scheduling. They manage that themselves. And as you'll have understood, often when working with orderlies, they used to just be on short-term contracts, and now when you tell them that they can manage their own schedule, it makes it more appealing. Maybe it's also quite scary for them. It was not all easygoing. And thanks to these digital tools, however, the staff are now autonomous. They work on the admin as well. They interact directly with other healthcare professionals. And I think the healthcare professionals were not used to this either, and our caregivers really realize that they can now be part of a holistic care system focused on the patients. And this was something which really, I think Barbara agreed with me, that the staff are really enjoying this. They also feel independent, autonomous in terms of controlling the costs and the stocks linked to our care. They organize their shifts, their rounds, and another major challenge still for us today is that the staff organize the recruitment, they meet the candidates, they hold job interviews with them. There's supervision led by the director, nurse / coach, but really it's a huge change for our teams at La Vie Active. So the clip shows maybe the positive side of things, but now in October 2022, despite the pandemic, despite all difficulties we face, our team is pretty unanimous on the fact that we want to continue with this adventure. We want to continue working with this new model. And as you will have understood, I think there might be questions if I'm not clear, but I think you will have understood that we're not just working on our own. We're working with partners. As you know, home care service, we can decide our own rates. It's the regional health agency in France that decides the rates based on a decree, the governmental decree. So we cannot say that we can control all of the rules. We have to follow the rules, but sometimes they limit our capacity to be able to go off the beaten track, as we were doing with this experiment. So really we are trying to disrupt things and change things. So now we're getting towards to the end of this experiment, and now we want to move on from an experimental phase to a long-term sustainable phase. And that's why next week our association, La Vie Active, with Barbara as the representative, will be going to meet the ARS, the Regional Health Agency, to tell them how this experiment has been really positive for us. I'm going to ask the ARS, how can we work to ensure that we can use this system in the long term? We've always kept the Regional Health Agency informed all throughout. They approved us with going for this experiment. And then we've given them an intermediary report, and at the time they said it was a good thing and carry on with it. And so now next week, I hope, anyway, that's my opinion, that the ARS will give a positive feedback on this transformation. We've realized here in France that other authorities which set rates, it could be at the departmental level in France, it depends on which region you are, but anyway, the authorities which decide on the rates in France, some of them are now sending out call for tenders to try and experiment with the self-organized Buurtzorg model. This is what's written in their call for tenders. So I think that Buurtzorg, as Jos, I'm sure will agree, is inspiring people, and the lots of different local authorities and funding partners have heard about it. They have a positive vision of it, so we hope that the ARS will approve that we can continue to use this model next week. So yeah, maybe there are questions or comments at this point. I know that Peter Brook will also be speaking shortly. It's nearly 3:30, so I'm not sure if I've got any time left.
Yes, Pierre.
Yeah. Well, thank you, Pierre. There are a few minutes left for Peter to have a little input.
Thank you.
So over to you, Peter.
Yeah, thank you. I just want to talk about what we've been doing at KCHFT. I totally agreed with what Alison Mills said from KCC at the start of the project. Our ambition was to have joint teams, very much joint teams of nursing staff and social care staff working together. We recognise that integration of care is so important, and yeah, we tried. We had workshops with the CQC. We had workshops with many people, and they're all very positive, but ultimately we couldn't get insurance. We have still taken this work forward with our teams. So we've worked with 87 teams across our organisation for a large community trust. So we deliver community nursing, we have health visitors, we deliver dentistry, specialist dentistry. So we have a range of services. And very early on in the project, I think it was Buurtzorg said that the engine of transformation is the team. So we made a choice at that point to very much focus on teams. So one of the things I'm really delighted that we've done is each of our teams does have a dashboard which they've helped design. So it's not someone like me or someone from IT is just saying, here's your information, here's your dashboard. We worked very closely with nurses, with clinicians to ask, what do you want to see? What information would be helpful for you to help manage your workload and plan your workload? And yeah, so that's been a tremendous development across the organization. That's going to continue after this project. And it's one of those things, it's just really sensible and really common sense to give people information so they can do their jobs in a good way. But as Rachel Way said earlier, traditionally our organizations have set up reporting to report on contracts. They haven't done it so that our own staff know what's going on. We've had some amazing results. So we've seen reductions in staff sickness across all the teams we've worked with. We've seen reductions in turnover. We've seen reductions in staff sickness due to stress. We've increased the time we spend with patients. We've seen reductions in patient complaints. We've seen reductions in patient negative incidents. So my sort of question would be, why wouldn't you do this? Why wouldn't you follow the Buurtzorg model? It's more respecting of the people delivering care, and it's more respecting of the people receiving care. I think that's all I wanted to add really, but I mean I agree with everything everyone else has said, that this is a hugely positive model, and we just need to carry on.
Thank you very much indeed, both Pierre and Peter. And indeed, Pierre, thank you very much for the film you showed earlier, and all the participants in that as well. Amazingly, we're running slightly early, which is good if there are questions coming in, and there are a few, and we'll do our very best to cover them all. But please keep asking those questions. And the first one is, I think, quite an easy one to answer. But I'll do my best with it myself, which was, how was the TICC project itself funded? The short answer to that, Livon, I hope I've pronounced your name correctly, is that it was funded with the support of the 2Cs project of the European Union. And by the support of, I mean very substantial multi-million euro contribution to the costs of the project, which was otherwise funded by the project partners ourselves. So the European Union funding accounted for 60% of the spend that each of us as project partners committed to the project over the last 5 years now because of the delay with COVID. And each of us found the other 40% of our costs ourselves. Therefore, although this project could not have been achieved without the contribution and the support of the European Union 2Cs project, for which we're extremely grateful, it also couldn't have been achieved without the very considerable financial contributions from each of the project's partners themselves. In our own case, for example, in Public World, running to more than a six-figure financial contribution ourselves, and all of the other partners made proportionate contributions. And I think that's important, and I'm glad you asked the question, because although it's important that the European Union has funded this, and thanks to that, we'll be able to provide a body of evidence and written material after the project, which couldn't otherwise have been achieved. It's also important that every one of the project partners had really significant skin in the game, that none of them were simply doing this because they were funded to do it. They were doing it because of their commitment to doing it, and the personnel costs and all of the rest of the costs have been a very considerable commitment from all of the partners. So I hope that answers that question. There's also a question which I can also answer from Cherise Guima, and again, forgive me if I've pronounced your name incorrectly, who's asking us if there is an interim report. The short answer to that, Cherise, is that there isn't, but you won't have to wait long for the full report. If you like, the interim report is the content of today's conference. And indeed, the conference content from today will be available to you after today. So please regard everything that you've heard today and everything that you can share from today with colleagues as the interim report. As I say, you won't have to wait long for the final report. Tom Malloy, the project leader, may say something further about this in his closing remarks, but you won't have to wait long. By the end of March 2023, all of the final report will be available to you. Now I'm going to move to the question asked by Chloé Ramy from France, who I think, who has, and I've used Google Translate to translate the question, but as she puts it in French, well, I'll do it in English. If I understand correctly, in France, there is no mixed nursing assistant team in the Buurtzorg model. Now, you may notice as you watch that we've gradually been joined by all, or certainly most of the panelists that you've heard from this afternoon. But I think that specific question is best directed to our French colleagues, Guillaume and Pierre. So I'll invite one of you, or both, if you like, to answer that one.
Oui, merci Brandon. Oui, Chloé, effectivement, dans le cadre du projet, en tout cas Interreg, nous n'avons pas pu avoir de dérogation, donc ça reste le cas. Il y a donc le SIAD de la vie active, lui a expérimenté la vision Buurtzorg au sein d'une équipe d'aide soignante exclusivement. Et pour ce qui est de soignants humains, donc c'était vécu au sein d'une équipe d'infirmières à domicile exclusivement. Et pour Vivat, donc des auxiliaires de vie. Nous n'avons pas pu, n'a pas réussi. En tout cas, voilà, s'il y a un deuxième projet TICC version 2, eh bien, en tout cas, c'est l'étape d'après qui reste à franchir, qui supposerait de déroger au droit commun là-dessus. Donc, tout à fait. Vous avez raison, Chloé. Donc, ça a été expérimenté, mais de manière cloisonnée. Auxiliaire de vie, aide-soignante, infirmière.
Thank you, Guillaume. Pierre, would you like to add anything?
Oui, peut-être, même si forcément, hein, vous l'aurez compris, moi, je travaille plus sur divers secteurs d'activité dans le secteur médico-social, donc je suis moins expert que Guillaume Alzac ou Arnold Fouquet. Mais l'intérêt aussi de ces programmes de coopération transfrontalière, c'est aussi d'aller s'inspirer d'un modèle existant dans un contexte bien particulier qui n'est pas le nôtre, qui n'est pas le modèle français, et d'aller s'en inspirer. Ça ne veut pas dire de faire un copier-coller, mais simplement d'aller tirer les bonnes pratiques et d'essayer de répliquer tout cela et de l'adapter, surtout de l'adapter à notre contexte particulier, parce que vous l'aurez compris, et Guillaume Alzac l'a bien souligné, il y a de multiples contextes de travail dans ce secteur d'activité-là en France, et donc de ne pas forcément le répliquer à la virgule près dans le modèle français. Donc on a quand même une certaine liberté, c'est quand même une sacrée opportunité de pouvoir tester, de s'inspirer, d'aller piocher en quelque sorte dans les expériences remarquables telles que Buurtzorg, et d'essayer tout simplement de faire bouger les lignes dans nos contrées, hein, dans notre versant français, tout simplement.
Thank you, Pierre. And as you say, it isn't possible to cut, and indeed not even desirable, to simply cut and paste the Buurtzorg practices into other environments, although much can be learned from all of those practices. But really, I always think that at the heart of Buurtzorg's success has been creating conditions for the professionals in Buurtzorg to find their own solutions, to create their own way of doing things. And that's the environment organizationally that needs to be created if you want to replicate the success of Buurtzorg, rather than simply looking at, oh, this is what they do, therefore this is what we'll do exactly, but to say, how do they go about deciding what to do? How do they go about creating solutions on the job as they go every day? Because that's the kind of organizational environment that is required. And so moving on to the next question, which comes from Natasha Parry from NHS England, and thanks for this one, Natasha. And her question is open to any of you. Are there any examples of multi-professional teams in this model rather than nurse-focused? Now, there isn't anybody on this panel from Buurtzorg in the Netherlands itself, and I can answer that question about Buurtzorg Netherlands if needed. But first of all, let's see if in France or with our Kent partners, whether you have tried giving expression to this approach in multi-professional teams rather than as in Buurtzorg with nurses and nurse assistants in the Buurtzorg teams. Can I invite anybody on the panel to put their hand up and say if they'd like to comment on that. Over to you, Peter.
Well, Alison Mills might want to come in here as well, but at the start of the project, our first pilot team in Edenbridge, as Alison said, it had social care staff who were recruited by Kent County Council through their contracting system, and it also had a professional OT, again supplied by Kent County Council, working with NHS nurses, and the staff in the team absolutely loved it because they were having their horizons broadened. They were seeing patients much more holistically. They were seeing issues that they wouldn't, and as you said, Brendan, solving issues that they wouldn't have even been aware of if they'd stuck to their professionalism. And it's a, you know, I'll be honest, it's a little frustrating for me that now in the UK we're moving towards, you know, integrated care systems, integrated care boards, place-based partnerships, you know, primary care networks. This model where you've got, you know, an autonomous team that can build solutions around patients is a perfect model. And I just think we need to be braver and bolder and quicker to provide the solutions for patients. Alison, do you want to comment?
Yeah, just to kind of replicate what you've just said, the Edenbridge team pilot was a real starting point, I think, and was a real introduction to TICC and the Buurtzorg principles and everything we were trying to achieve. From a social care point of view, we also tried to turn the Buurtzorg model a little bit on its head, where we set up a social care team, and we had OTs in the team. OT assistants, and we had care workers at different levels as well. And they worked in a local neighbourhood in Ashford. They had a very small postcode area, which they were aligned to a GP practice. So trying to reduce travel costs, everything that the Buurtzorg model obviously has implemented. That worked really well, and we were looking at strength-based conversations through the OTs, holistic model of care, care and support as and when it was required. And then what the social care team would do would be then to call on a nurse practitioner or a nurse or someone from the GP surgery. If a health assessment was required, we would then contact health, and then they would come in and work with the social care team. Unfortunately, due to the pandemic, we had to disband the team because they were being pulled in different directions and were ending up doing time and task again, which wasn't part of what the pilot was all about. So we did decide to disband the team. But I think if it wasn't for the pandemic, I think we could have potentially continued and seen that team grow and develop a bit more as part of this TICC pilot.
Thank you very much, Alison and Peter. Would anybody from our French partners like to respond to this question? Put your hand up if you'd like to, please. Go for it, Pierre.
Pour vous faire part de notre expérience, du coup, à la vie active, comme je vous le disais tout à l'heure, l'expérimentation TICC, c'est donc uniquement cette équipe-là. Mais sachez que parmi les 90 établissements et services de notre association, nous n'avons pas caché cette expérimentation, nous l'avons partagée à des collègues qui, pour certains, des managers notamment de ce que l'on appelle en France des services d'éducation spéciale et de soins à domicile, encore un autre acronyme, on aime beaucoup les acronymes en France, un CESAD, qui est destiné à accompagner les enfants en situation de handicap et leurs familles. Et donc, vous l'aurez compris, constituer d'autres organigrammes avec d'autres types de professionnels, il se pose sérieusement la question comment pourrions-nous s'inspirer aussi de ce modèle managérial pour l'appliquer dans cet autre contexte. Donc aujourd'hui, ce n'est pas encore effectif, mais sachez qu'il y a une vraie réflexion au sein de notre association, puisqu'on s'aperçoit qu'il y a quand même de bonnes choses à tirer de ce modèle managérial.
very much. And I'm delighted to say that having noticed that Jos de Blok is still with us and that he's put something in the chat box about Buurtzorg tea, I've asked our tech friends to add him to the panel. Jos, welcome back. It's fantastic to have you with us. Jos, would you like to respond to this question or indeed any of the others?
I was listening to the discussion about the multidisciplinary teams, and there is a kind of a logic in what are the problems of the patients or the community, and how can you create a solution that you're not using a necessary time in all kind of coordination and meeting things. So if you look at the nursing part, it's logic that nurses are available 24 hours a day in the neighborhood. And when they need another discipline, then they build kind of an informal network where all the disciplines are involved. So in our nurse teams have connections with social workers, with psychologists, and with other physiotherapists and so on. But they only focus, or they only use it when it's needed. So the needing principle is a very important principle. If we have Buurtzorg teams, and if there are mental problems, there are different kind of disciplines which can contribute to this problem. So you have the psychiatrist, you have the psychiatric nurse, you have social workers in these teams, and for the mental care, this is a logic way of the consisting teams, and it's working very well. So it depends on what kind of problems you want to solve and how you can avoid unnecessary communication and coordination. And I know what just Peter said about the integrated teams in the UK. There is a similar development in other countries, but it's usually it starts from top down, so it's not from the patient perspective. So my idea is we should always start with the patient perspective, and then what is logic in how to organize and what is needed, and then we should focus on networks instead of structures. So the whole idea of structures and systems is one important part of the problem. So Ingrid, I see you knikken. In Holland now, it's really so we had now the legacy of the former minister, and the whole country is talking about things, and it's not about patients but collaboration. And most of the meetings, the goal of this collaboration is missing. So there is a solution for a problem that's not there. So if you start with, okay, we need, for example, if you say we need more focus on prevention, then you first should discuss what it should be about and what kind of interventions you need and who should deliver these interventions, and then you can integrate it in the different disciplines. But what we do is, from a kind of an organizational perspective, we do it the other way around. So we put all the CEOs together, they talk about these things, and they come with a structure. That's usually the result. So, and I said we have the consistency should be that you have patients and you have healthcare workers, and they can create solutions for these patients. And everything what you do, what's not needed, is a pressure on the system. And it costs a lot of money if you do it that way. So, but I don't know if you can add something on that, Ingrid, from the Dutch context. But what I would like to show is that if you do that consistently throughout the years, then you see the decrease of costs every year. So, and that's you see it back in just in money wise, but you also see it back in that it's attractive for nurses to work this way. So you see that our problem with getting new nurses is much less than our colleagues in Holland. So, and the patients are still very about the way they are treated. This is what I would like to say about it. Last question I couldn't hear, Brandon. I was doing my technical change to get into the meeting.
Well, thank you, Jos. We'll come on to that. But I just firstly want to see if Ingrid, whom you've tagged, so to speak, would like to come back on what you've said.
Oh my gosh. Yes, I was nodding, Jos, because I recognize what you're saying, but this is more like a personal thing, except besides our role as a evaluation partner. But it's basically what you say is when you put the patient central, it's a service management idea. So you just combine the ideas based on the main actor in the process. And of course, it's not the patient alone, it's also together with the healthcare workers, of course, because that interaction is very important. So that's why I was nodding. I recognize what you're saying, and the interaction is very important between those people within the process. So the process should be helping the interaction. It's not a goal itself.
Thank you, Ingrid. But Jos, I'd like to just follow up on this point about multidisciplinary teams and so forth, and the systemic and structural challenges. And let me bring in some of the experience we've had from outside of the TICC project in the wider work we've done in Britain and Ireland. In Scotland, we worked with a number of organisations, and two of them were quite similar organisations. And one of them, and in one case, they decided they wanted, quite rightly, I think, and this was inspired by Buurtzorg and trying to overcome a structural obstacle in the system here in Britain. They wanted to provide holistic care to people locally. And so they wanted to break down the barrier between nurses, who in Britain are employed by the National Health Service, and social care workers who are employed, if not by, then through local government, municipalities. In one case, what they decided to do was bring these workers together into a single team, although they had different employers, and each of those employers had their different pay systems and so forth. And IT systems for that matter. And in the other case, what they decided to do was not worry about the fact they had different employers and different structures, but actually to enable the professionals themselves in their different organizations at local levels to network together and find solutions together. And the experience was that the first of those, which to many system leaders might seem the logical thing to do. You want to integrate services? Oh, right, so integrate the organizations. That didn't work. What did work at local level was where the professionals themselves were able to network and find solutions together, regardless of the fact they had different employers. So look, that's a very leading question, but I suppose what I'm suggesting, all I'm doing is describing something factual from our experience here in Britain. I wonder if you've got any observations about that, Jos.
Yes, it's for me, it's the same reason that we have separate teams for domestic care and for nursing care. So the community care and the domestic care have two different dynamics. So people think indeed that if you integrate this, that things become better, but it has a very negative influence on, for example, productivity. So if you there are two reasons not to do it. One, there are just 20% of the patients where both are. So for that, you should not do that. But the other thing is that if you have too many different levels of education in one team, it's always hurting the highest and the lowest level. So you should have a collaboration in a team where people have kind of similar language on how to deal with problems. And in Holland, it's the bachelor nurse, the registered nurse, and the nurse assistant. There is a logic in that. So, but you saw in these examples, and what you just described is what I say all the time. The network should be based on what is needed for the patients where you are delivering the care together. And then it's easy to find each other. That's no problem. But then it's just for that one or these few patients. And there are different ways to deal with it. If the amount of patients where you are sharing care together, then, for example, one of the nurses of the nursing team is coming to the other team of the domestic care once in a month, just to discuss the patients where you share the. It's a much, you can say a much cheaper solution than integrate everything. Integrating everything is the most expensive solution. Another topic which is also very interesting is where are how far can you go in integrating this in one person? So because communication within yourself is much easier than communicating with other people. So and what I shown in I wrote a note for the Dutch government some months ago, and they didn't read it yet, but it's about integration. It's about integration and combination, because throughout the years we cut the profession of the community health nurse, the district nurse, into 12 pieces. So in 30 years, because of the payment system and because of the changes in the system, what was done in the 80s by one person is now done by 12 different people. So the system by itself created so many coordination and so many problems by disintegrated. And for me, if you look at the future and the demographics and the availability of healthcare workers, we need to integrate. So you can make the work more attractive, more flexible, and things are becoming more attractive for young people to join. So for me, the future is about finding ways to integrate activities in one person and make jobs more productive and more attractive. So that's so and these discussions about integration and teams is all about the way we started to think from a management perspective. It's not, and it's usually focusing on kind of idea of efficiency and a kind of collaboration, where the assumption is that collaboration is useful. So we put people together and they become very busy and they have a lot of meetings, but the connection between what does it bring us as for the patients and for the professionals is not measured at all. So this is what I would like to say about this, but
that's absolutely great, and actually couldn't be more timely from the British, or at least from the English point of view, with the institution in the currently of integrated care systems at local level, and I think what we're finding there is that some local leaders are interpreting this opportunity as being another way of trying to find ways to integrate at the top, and you end up with lots of arguments about who gets what job, whereas others are seeing it as an opportunity to do what you're saying, which is to start from the needs of the people needing support and integrate around that and create the networks that are needed. So I think that's very timely from the point of view of England, and for all I know from France too. So let me see if any of our other panelists would like to come in on this topic before I go to what will probably be the final question. Okay, there is something in the chat box, however, from Rachel, which I'd like to ask Rachel to come back in on. We've heard a lot today, particularly in this session, about the professionals and the how important it is to create conditions in which the professionals are able to do a great job. But I know for you, a lot of the motivation of the work that you do and have done in the TICC project and with us generally over the last 4 or 5 years has come out of your personal experience. Would you like to say a bit more about why that's important?
Thank you, Brendan. Yeah, I was. Oh, hang on, need to mute myself on the other one. Yeah, it's really important from a personal point of view. Every single one of us is a family member, is somebody that looks after people in some way, shape, or form. And I think it's very easy to think about this in a professional way in our jobs. But actually, my experience when my grandparents were poorly was at how broken our system was, how little they thought about the patient, how little, and this has come up a couple of times today, how little support the caregivers, the informal caregivers, the people at home, how little support they get given to learn how to care for their family and friends. Nobody taught me how to look after my grandma when she had dementia. Nobody taught my mum how to liaise with my granddad when he wouldn't accept any care. And so the connection with it all is so personal to each and every one of us. We will all have some form of experience as to the better ways to do things. And it is a personal driver. It's very much a motivation. And when I think about the care my grandfather received specifically, you know, I will stick with this until we make it happen, because it is the way forward. It is the only way forward. His last few weeks, he was a man that got up at 6 o'clock in the morning and made breakfast for everyone. He stayed up until 11 o'clock at night, and his day was reduced by 6 hours by the care that was given. So he lost the quality of his day. He lost the opportunity to do many of the things he loved because the care couldn't be provided in the way that it needed to be for him as the patient. So yeah, I picked up on it in Ingrid's point. It's from a very personal point of view. It matters to each and every one of us. It really does.
Thank you very much, Rachel. One last question that's come in, not on the. I'm sorry.
Brendan, I don't think you saw
who
my.
have I missed?
It's Peter. I don't think you can see my hand.
Apologies, I didn't see your hand.
Yeah. So I just wanted to come back on the point that Jos was making, because one of the sort of triumphs we've had as an organisation, and it's like, it sounds like such common sense, but the old way of doing things was if something wasn't working, you know, you'd talk to your manager would talk to a senior manager, that senior manager would contact the partnership organisation, that senior manager in the partnership organisation would then contact the local manager, that local manager would then talk to the team. That's exactly what used to happen, and you know, working in silos. One of the joys of this project has been coaching with teams and saying to teams, who's the best placed person to talk about this patient's care with the local pharmacist, with the GP, with the OT, and empowering and encouraging that team to have that conversation. So, you know, not involving their manager because they don't need to, because they're empowered to be autonomous, to be to just do the right human thing, which is what this project's all about, humanity at the heart. So I just wanted to make that point that, and I totally agree with what Jos was saying about, and what you were saying indeed as well, Brendan, about too many sort of structures and things being driven from the top down. We've got to get much better at empowering people at community level.
Thank you, Peter. So one last question that's come in by a different route. Jos, you shared with us this morning what many of us will have found, even if we thought we knew everything about Buurtzorg, to be an astonishing fact, which is that despite your great success with quality of care and professionals' working lives, community nursing came in actually under budget in the Netherlands. We, I think elsewhere, I mean, we certainly do in Britain, find often that the organizations that are drawn, not often, that's unfair, but occasionally we find that organizations that are drawn to Buurtzorg in the health and care system are attracted by the fact that Buurtzorg has not only provided great care and great working lives, but also has reduced costs. And what we tend to say to them is, if you focus on cutting costs, you probably won't cut costs, and nor will you achieve the other benefits that Buurtzorg has achieved. But if you focus on the basics of Buurtzorg, you will not only likely achieve better care and better working lives, but the costs will take care of themselves and be falling over time. Again, it's a bit of a leading question, but I wanted to ask anybody here if they had any observations on that point, or indeed yourself, Jos. Put your hand up, please, if you'd like to have a go at that one. I don't see any hands. Have I not stimulated anybody to come back on that? Jos, is there anything you'd like to say about that before we close? I think you're on mute still, Jos. Jos, you're still muted. Have we lost Jos? That's a shame. I was hoping to hear the answer to that question, but unfortunately we're running out of time. Let's just give a moment to see if Jos can come back in. He's trying to get in again, of course. Is there anybody else who would like to... there's one more question which wasn't answered from this morning, which came in from Sue from Aldingbourne this morning, which is why politicians don't engage with this when surely it's a win-win for them. Perhaps they do in some countries, perhaps they have in France. Guillaume, would you like to come in on that?
Yeah, several answers. Maybe the first one, it's our job to get them involved. So I think it's our responsibility. But also, of course, it's quite technical issues. It's not mainstream. It's quite, I mean, you need a few minutes to discuss. So it's not a headline on TV show issues. Also, I believe the home care nurses, nobody knows unless you need it. And usually you need it when you're close to dying. So I think our politicians, they will understand the thing at a moment when they do not have any power anymore because they will be going to die. So usually they're more focused on the medical, on the doctors and the hospitals. And it's like the home care doesn't exist. So I think it's part of our responsibility to explain to them with simple words. I think Jos has been doing a great job for this. And we need to get inspiration from him also on this. How can we engage the politicians on this? Because the topics are quite complex. They are not so attractive to them. And they are not apparently the main issue in our health system. They think more about the hospitals or the doctors than the nurses or the home care environment. And yeah, but I see now, at least in France, because 30% of surgical places are closed down because they lack nurses. So now they understand it may be a good idea to see what the nurses, who they are, what they need, and why are they leaving. and until now they were mostly thinking about doctors, because there are doctors. The lobbying of doctors is bigger, and pharmaceutical, of course, and the lobbying of nurses is almost non-existent, because they are caring for people, so they don't have to spend time on lobbying. So now, okay, things are changing a little bit, and I think we have quite some hope in France now that the things are moving. But I think it's our responsibility to let them understand simply what it's all about.
Well, I think that's a great message to finish, to end this part of the afternoon session on. We're going to move in a minute to the closing presentation from David Stewart of the International Council of Nurses. But before doing that, I want to thank all of our panelists. I won't go through you by name, but thank you all. I want to thank Jos for joining the panel this afternoon, and for staying all day, and for inspiring with his organization the whole day, and indeed the whole project. I want to thank the interpreters who have been working away so diligently and skillfully in the background. And I want to thank the tech people who have been doing the same and have made this quite complex arrangement today possible. And now Jos is back, but we're out of time, unhappily, Jos. So I'm going to turn over to the video of David Stewart. Because David is in Australia, we invited him to provide his presentation in the form of a video, and that's what you're going to see next. Thank you very much.
Hello, and thank you for the opportunity today to actually share with you on behalf of ICN what I see as a most important innovation when it comes to the delivery of healthcare. And I want to talk about this renaissance in primary healthcare and community care, and the requirement to invest in innovation in nurse-led models of care. So I hope you're having a great event and a great conference. As probably mentioned, my name is David Stewart, and I work with the International Council of Nurses. I've worked in the nursing and health policy team now since about 2016. And I've had the pleasure of working with many great nurse leaders from across the world, including those within the Buurtzorg community. Look, I want to talk to you about some of the key challenges and some of the key problems that we have globally when it comes to community-based care and primary health care, and the need to change things, to do things differently. And a good example has been particularly with the increase in non-communicable diseases, where not just communities are suffering globally around the world. It's a issue that is affecting everyone everywhere. But large numbers of people are not just suffering from one chronic condition, but sometimes multiple. The United Nations and the World Health Organization, in the development of their Sustainable Development Goals, has called for a 25% reduction in non-communicable diseases by 2025. And that's particularly through investing in primary healthcare and community care as well. And part of this solution that they see is that we really need to strengthen this multidisciplinary health workforce, especially those working in community. And we also see that they have great benefits if we actually do this. Not only will we reduce morbidity and mortality, we will also have a significant return on investment as well. And so they actually say that for every dollar spent on this, there's a potential to have a $7 return on investment. We recognize as well that as a result of fighting this pandemic on a global scale, that core health services have been majorly disrupted. And if we even looked at, say, potentially mental health care, we've seen globally that the vast majority of mental health care particularly those within the community settings, have been majorly disrupted. And now we're seeing some of the consequences of this disruption, and we're seeing excess mortality across the world that is non-related to COVID. And so, for example, within the United Kingdom, we're seeing an excess of around 1,500 deaths every week, with 80% of these not related to COVID. And so this disruption to accessible and good quality care within both primary healthcare or community care is a major challenge, and it needs to be addressed. But we see that there's also been huge challenges when it comes to the health workforce. And I think this is very relevant as we look at why do we need to change the way that we do. And one of the big reasons is that there are massive workforce shortages, both in all health workforce, with around 15 million shortfall by 2030. But in particular, there is a 6 million current nursing workforce shortage across the world. And I think this may be a significant underestimate with what we know is the impact of COVID, but also some of the issues around professional practice barriers, the constant heavy workloads and under-resourcing of the profession, and the burnout and stress. And so what we see now is potentially a 6 million nurses short now. We are estimating that this could actually get as high as 13 million nurses short by 2030. And that has massive implications. And how do you sustain and develop this workforce to meet the health needs of people into the future? I mean, the obvious things that are being put forward include, you must increase that domestic supply, or what about overseas recruitment? Look, those things are very good and are very important, and particularly with how do we do ethical migration. But one of the things that I see as really pertinent to this conversation is we actually must also focus on retaining the nursing workforce. We must retain them and use them to the best of their ability. Don't lose what we've already got. And whilst there are a number of things that need to be done, there are some core challenges that could improve this situation. Part of this is that we need to look at reimagining the possibilities of nurses working in primary health and community care. And we might need to look at how we can optimize this existing workforce. The OECD recently released a report, and they found that in their countries that they surveyed, 75% of doctors and nurses reported being overskilled in the roles and responsibilities that they have in their daily life. I mean, that is a big contributor to poor satisfaction in the workplace when you're not using your skills effectively. And, there's a large number of physicians that say, much of this prevention care and much of this chronic care can be delegated to others. We're not using our skill sets appropriately. And if we can actually optimize those nurses working across the world in different areas, it's an incredible force for change. Most of you would be aware of or know the quadruple aim of healthcare, to achieve high quality patient care. What does it require? There's always been a lot of focus on 3 elements, which was that triple aim. And more recently, there's been this 4th element added, and I'll talk about that shortly. So the elements required to achieve high quality patient care start with making sure that it has improved affordability and cost efficiency. It must have significant value. In addition, not only does it have to have value behind it, but it has to improve the person's experience, their experience of care, being involved in decision-making, shared decision-making, what we term people-centered care or person-centered care, meeting the community needs, addressing not just their immediate condition, but that elements of the social determinants of health. And of course, we need to look at how do we improve the outcomes for patients? How do we improve the health of populations? And so those elements, whilst they are crucial, are highly dependent on a workforce that can meet the needs. And we need to make sure that we're looking at how do we improve the work life of healthcare providers. Mark Britnell, who wrote a great book on sustaining the future health workforce, says this very quote. He says, "How can you expect people to care if they do not feel cared for as well?" And I think that's why that quadruple aim has started to focus on, we need to focus on improving the work life of healthcare providers as an essential element to how we look at healthcare. If we can do this well, if we can make changes happen, and if we can implement the science and the knowledge that we already know, we can have a massive reduction in the global burden of disease, but also we can have big benefits to the global economy. So we need to imagine or reimagine the possibilities of primary healthcare and community care in moving away from a system that just treats illness to one that also considers well-being. And just changing that philosophy from what's the matter with patients to what actually matters to patients. And instead of just focusing on treatment, providing on health promotion, prevention, safe environment, helping people to be self-managing care. And instead of being uncoordinated care, moving towards a coordinated system that values individuals and values the outcomes. One that is coordinated and not fragmented. These elements we see as core components of this model of what can you do, these self-managing teams. And the Buurtzorg model has been a very fantastic example of how much of this is being achieved and how this is being implemented in real life. But it is also an important issue because as we start to look at the health workforce, we know that there are key things that we must do to keep and retain and sustain this workforce. We need to make sure there is good recognition, particularly as it comes to professional autonomy. We've got to allow people to work in innovation models. We've got to optimize their potential without having these artificial barriers stopping them from doing work. We need to reward them by having this higher professional status, having their skill set being utilized appropriately. And hopefully we can also respect the great and enormous work that these guys do, the people do within this. And of course, we also must look at remunerating these elements. If we can do these elements, there are big benefits when it comes to sustaining and retaining nurses. We know that when we start to optimize these roles through different forms of care, whether it be hospital in the home, whether it be nurse-led clinics, or even multidisciplinary teams with a focus on prevention, promotion, and treatment and self-care, big differences can be made. Huge benefits. And so there are many benefits, not just to the nursing profession, but also to the system as a whole. And so when we look at models like Buurtzorg, where there's that ability for teams to be self-directed, to engage directly with the community, to use their skill set, that's where we see significant change and innovation start to flourish, where we see greater savings for the health system, we see greater patient outcomes because people have the ability to use their skill set to improve and engage with the community and people in a much better way. And so we see the outcomes of higher satisfaction, better cost of services. Lastly, we also see that it meets the health needs that are coming. Issues that I mentioned earlier, particularly around chronic disease care and managing multiple conditions and helping people to better self-manage. there is significant benefits that can be achieved if we start to look at innovative models such as Buurtzorg and start to look at how can we utilize what's been learnt in this and start to implement it in our kind of way in community. At ICN, we're not going to endorse any particular model, but what we do want to be able to share is when things work well, we want to make sure that that is shared and that is seen by the global community. We want to be able to share that story. And I'm happy to say that, you know, this model is one that we are more than happy to share because we believe that there is evidence behind it in improving the outcomes for patients, improving the cost efficiency, improving the health of populations, including their satisfaction, but also it does improve the health and life of healthcare workers that provide that care. I want to say thank you very much for the opportunity to talk to you today and acknowledge the support that this organisation has provided to us. Thank you for this time today. See you soon. Bye.
Thank you very much, David, and everyone again. And I'm going to hand straight over now to Tom Malloy. Tom, you're on mute. I had this problem earlier, Tom. Just keep trying, it'll happen. Okay, maybe it won't.
How about that?
Oh, here he is. Yeah, well done, Tom.
Okay. Good afternoon, everybody. I'm Tom Malloy. I'm Senior Project Manager at the Health of Europe Centre. Alice, who opened the day, can't be with us at the end of the day, so it falls to me to close proceedings. Firstly, a reminder that the videos that were shown at lunchtime, but I know that not everybody will have had a chance to see, will be shown almost immediately after I formally close things in a few minutes' time. So don't close this link down if you want to see those videos. However, you will also then receive in the coming days an email from Santé, our communications partner who organised today's event, with the links to a number of things, including the documents and so on from today, to the TICC and Buurtzorg community site that's been mentioned earlier, where you can engage in some networking following on from this. And also, there will be the link for the legacy site. That site is not live right now, but do make a note of the web link. It will go live in due course, and subject to appropriate GDPR things, we'll let you know where you can access that in due course. The final documents for the project will go on that site once they're ready. In practice, the blueprint and the final evaluation are unlikely to be available until the spring. This is because obviously there's more work that still needs to be done on them, and also we'll need to translate them. So please bear with us, but keep in touch with whichever of the partners you have access to, or via the links you'll be sent in the meantime if you want any more information. So, firstly, I want to recognise the role that the European Union's European Regional Development Fund has played in this project through the Interreg 2Cs programme. As has been mentioned earlier, they funded essentially 60% of this work, and therefore without their support, this project wouldn't have happened. So thank you very much to Interreg. Secondly, I want to recognise the partners who've been involved in this project: Kent County Council, Kent Community Health NHS Foundation Trust, Medway Community Healthcare, Soignants Humains, Public World, Woonzorg Emmaus, Santé, Vivat, Groupement des Hôpitaux de l'Institut Catholique de Lille, HZ University of Applied Sciences, La Vie Active, and Buurtzorg. Thank you very much to all of you. We very much appreciate the role that you've played. Today, we're all very grateful to the keynote speakers who provided inspiration and insight and provided different perspectives on what we've done. And that was Jost Bloch, Marie Gérard, Geneviève Manerino, and David Stewart just a moment ago. And thanks very much to all of the speakers and facilitators through the day, who I will not embarrass by naming by rote, but particular note to Helen Martin and Brendan Martin, no relation, for coordinating the morning and the afternoon respectively. Final thanks go, of course, to all of you who've participated here today and to those of you who'll be taking the time to view this by video later. I want to thank Santé, who've organised today's event, and to Vimit, who is the technology provider, and also to the interpreters who've been working hard behind the scenes. I'm afraid I don't have your names to be able to recognise you personally, but thank you very much anyway. As I mentioned, please do keep in touch in future. Watch out for what's coming out in the spring from this project, and we look forward to hearing from you again in future. Have a wonderful weekend, and thank you very much, everybody. Good evening.